morning, everyone. And thank you very much for giving me this opportunity to speak in front of senior colleagues of our specialties. And I thank Corona Remedies also for organizing this wonderful meeting early in the morning on Sundays, where usually we know that in the human body, the organs will have a crosstalk. And occasionally, specialty doctors also should have a crosstalk so that they can learn from each other. And of course, it's a mutual learning process for everyone. And we learned a lot from the diabetologists and the endocrinologists and the cardiologists, and the diabetes being the leading cause of chronic kidney disease and end-stage renal disease across the world, more so in our country, where it is the diabetes capital in the world. And we know that most of the patients admitted into the intensive care, they develop acute kidney injury, which significantly contributes to the mortality and morbidity. Not only that, even in the outpatient clinic, we try to see some of the patients where the sudden deterioration will certainly takes place, and over a period of time, they slowly come back to us with a established chronic kidney disease over a period of time. And we try to elucidate what could be the reason for that. And we find a lot of clinical situations where the patients would be taking so many drugs, that whatever maybe either it's an SGLT2 inhibitors or any antibiotics, or the NSAIDs and the proton pump inhibitors, where they can lead to acute kidney injury, and they slowly develop chronic kidney disease over a period of time. And the diabetes is the most common cause of underlying etiology for them to make them more vulnerable to develop acute kidney injury. And these are the patients who have got unique characteristic features of the kidney, which makes them vulnerable for acute kidney injury with a consequent chronic kidney disease. Today, I would like to speak a little bit about the acute kidney injury, the conundrum, which ultimately becomes chronic kidney disease and end-stage renal disease in our group of people. Diabetic patients, because of the unique characteristics which are taking place histopathologically within the organ, are more vulnerable. There are several microvascular complications that take place in the kidney. And one such thing, several associated features like coronary artery disease, peripheral vascular disease, and strokes, the major micro and macrovascular complications, all of them put together, they come to the hospital and they will be having multiple drugs, therapies of various reasons and various indications, and which makes them vulnerable for acute kidney injury. And for the past several decades, there is so much of a change in the management of patients with acute kidney injury. But unfortunately, the risk of morbidity and mortality did not change. And more than 50% of the patients who are admitted into the intensive care with acute kidney injury, they die of complications. And this number is the same for the past few decades. And we have improved a lot. We have improved with drug therapies, management of the critically sick patient, and management of dialysis therapies in the form of continuous renal replacement therapy, CRRTs and SLED, and different varieties of absorption technologies in the dialysis management with the filters, and so many other things. And intensive care also has improved over a period of time in taking care of the patient in general. Despite that, the AKI is the same, and the mortality associated with is also the same, around 50% and above that. And we could not really change much. And among them, the diabetic patients are the most important group of people who have highest morbidity and mortality with acute kidney injury. And because of the several complications, they get into the intensive care and they succumb to the illness, where the AKI contributes significantly to their mortality. And we know that the Morgensen's classification of the changes over a period of time that takes place within the kidney in patients with the diabetes. But this is classically described with type 1 diabetes, which not exactly the replicates in patients with the type 2 diabetes. But however, most of the patients with the type 2 diabetes also will have some of the changes which they certainly take place irrespective of the duration of the type diabetes. In type 1 diabetes, we have a duration-based changes in the kidney. That's something like 5 years, 10 years, 15 years, and 20 years, where the glomerular basement membrane thickens, and over a period of time, it leads to ultimately the hyperfiltration, followed by hypofiltration with a microproteinuria, followed by overt proteinuria, leading to the chronic kidney disease changes with established fibrosis of the kidney with a diabetic glomerulosclerosis, leading to end-stage renal disease. But here, even in type 2 diabetes, also similar changes take place initially to start with the onset of type 2 diabetes, where there can be some hyperfiltration initially, where the GFR will go up, then gradually GFR will fall down with the proteinuria from micro to macro to overt nephropathy, And proteinuria is a surrogate marker not only of the kidney dysfunction, but also equally that of coronary artery disease, where they die significantly with the coronary artery disease and its consequent mortality. So our patients are with the proteinuria are more vulnerable for other complications also, which makes them vulnerable again for the kidney injury which takes place with any of them. And this is basically the histopathological changes which take place over a period of time with the hypertrophy, hyperfiltration, and the glomerular disease with any clinical disease, but then incipient nephropathy and over nephropathy and end-stage renal disease. These are the classical the histopathological features in association with the clinical features, and end-stage renal disease is the consequent of that. But interestingly, several of these patients would have had several episodes of acute kidney injury in general, which are many a times subtle, which many a times may not be noticed in a significant way. And unless they get admitted into the hospital and they get treated for that, they get improvement partially or completely sometimes, but very rarely. But partial improvement is also seen in them, and they get into a clinical conundrum called AKA conundrum. Here it is acute kidney injury to start with, and which is defined as the one which where the acute kidney injury persists for less than 7 days. And of course, the definition of acute kidney injury differs, and almost it has been known that more than 36 to 38 definitions are given to AKA. But the three major definition protocols are there for the AKI, and it's more than 50% fall in the GFR in less than 7 days. It is a classic, and in association with the increase in the serum creatinine and oliguria for more than 6 hours. And here it is an AKI is called only when it is persists for less than 7 days. But AKD is the one which persists, the AKA, the kidney injury persisting for more than 7 days to less than 3 months duration is called acute kidney disease. The acute kidney disease is also marked by the fall in GFR, increase in the creatinine, and further continuation of the oliguria or anuria. And when the disease, the kidney disease and the kidney injury persists for more than 3 months, it is called chronic kidney disease, where the persistent fall in GFR by less than 60 ml per minute. And there are several markers of kidney injury which can be detected when it is an AKI, AKD, or CKD. But unfortunately, none of the biomarkers which are known or existing in our current literature are able to clearly and classically depict the ongoing onslaught of injury which is taking place within the kidney, unfortunately. But still, we bank upon the proteinuria, creatinine, urine output, and these are the major three parameters, unfortunately, on which we depend rather than any early marker, something like a biomarker, something like an NGAL, etc., which could not really make any difference either clinically to the clinician or either predicting the prognosis or the therapy otherwise. When it is going to persist for a very, very long time, these patients of CKD progress over a period of time to get into chronic kidney disease. And most of the patients who are admitted into the sickness with AKI in intensive care setup are having diabetes. And most of the patients are vulnerable because of the presence of diabetes itself. The why diabetes makes them more vulnerable, and we cannot really make out any significant differential unique features about AKI affecting the diabetic patients when compared to the non-diabetic patients histopathologically. But clinically, we can make out that these people get an established AKD and CKD later when compared to the non-diabetic AKIs. That's why we have to take care and we have to follow them up for a very, very long time. Even any patient with diabetes gets admitted with AKI. So this is a simple picture which is depicting how the microenvironment within the within the glomerulus and which gets affected, and especially the renal tubular epithelial cells and the podocytes, they transform themselves into a myofibroblast and fibroblast with the deposition of fibrotic material by the TGF-beta and especially expansion of the extracellular material, and which the consequent secretion of several hormones locally, which can really make the environment totally toxic within the kidney and leading to the continuation of the AKI leading to CKD. So these people have more vulnerability and more at risk of developing progressive CKD and renal disease and death compared to those patients without AKI or without type 2 diabetes. But AKI itself in general has got several consequent complications in those patients, and especially the sick patients, even without diabetes. But with diabetes, probably the consequent risk of getting AKD, CKD, SRD, and the mortality gets quadrupled in these kind of patients. So this is a picture depicting how the AKI and gets transformed itself into the CKD with the presence of several the release of pro-fibrotic cytokines within the milieu of the kidney, and ultimately leading to an established chronic kidney disease in them. So several studies have been done, and how this particular AKI progresses to CKD, and also at the same time how to prevent and how to treat also further. And this is the the pathophysiology, which probably I will not be able to discuss much. And as I stated, we have so many biomarkers which can probably predict that these patients are vulnerable to make AKI into chronic kidney disease. The KIM1, NGAL, the KIM2, and IGFBP7. These are the several markers which have been utilized. Some of these molecules, especially the KIM1, could really make some inroads into our understanding about the pathophysiology of AKI in AKI, especially those with type 2 diabetes. But prognostic marker as such, we could not really develop over a period of time. There are several drugs have been used, especially that in cardiac angiograms, when these people are undergoing, NSL systems have been extensively used. And even now, every cardiologist passionately writes N-acetylcysteine to all the patients undergoing coronary angiogram. But in clinical practice, it could not really make any difference. And several studies, and more than 500, 700 studies which have been published, including our own Indian data, did not really make any difference as far as the prevention of occurrence of AKI or the consequent CKD when the patients were given N-acetylcysteine before the angiogram, or even the coronary cardiac surgery also at the same time. Similarly, the allopurinol, trimetazidine, in preventing the contrast-induced nephropathy, and several other drugs could not really make any difference as far as the prevention of contrast-induced nephropathy in these patients. Not only these patients with the contrast-induced, but the several other drugs, especially chemotherapeutic agents like cisplatin and several newer molecules, which really can lead to AKI, were also studied. But unfortunately, we could not get any major molecule at the drug therapy which can prevent the occurrence of AKI. That makes it more important for us to see that the prevention of AKI is more important, and the prediction of AKI is also equally important. And when to give a therapy, when not to give a therapy is also equally important. And rather than trying to prevent the progression later. So prevention is always important in diabetic patients who are vulnerable to develop AKI in either in the OPD setup or in the intensive care setup. So I've been discussing a lot about the intensive care setup, but there are several OPD situations where we can see some of the patients subtly developing AKIs. Now the most talked about the drug is actually SGLT2 inhibitors, and I think it's been already over now. The semaglutide has taken over the discussion part of most of the endocrinologists, cardiologists, nephrologists, and the clinicians as such. But SGLT2 inhibitors can really lead to a subtle change in the GFR with a fall in the GFR. I'm one of the principal investigators of the Credence trial in this country, and where we found that these molecules are wonderful in preventing the progression of the CKD and cardiovascular risk factors, as well as the improvement in the GFR for a very long time. And so we are also equally concerned about this particular molecule and trying to utilize them in association with ACE inhibitors and ARB. Sometimes these drugs are supposed to be given together. You all know that the ACE inhibitors, ARBs are the important molecules for us. We always try to start any diabetic patient or a non-diabetic patient with hypertension with ACE inhibitor or ARB. Predominantly the ARBs in the clinical practice. But SGLT2 inhibitors also are supposed to be given to these patients to prevent progression. But unfortunately, some of these patients are vulnerable for development of AKI certainly. That's why when we given a prescription of SGLT2 inhibitor, we should be able to monitor them frequently for the GFR, not only the other markers of sodium, potassium, and other markers, but subtle evidences of dehydration, which has been associated with SGLT2 inhibitors, probably can lead to AKI certainly, and there can be some improvement. So several studies have been done, and to know whether it is really important or not. In those patients in association with the RAS blockade and SGLT2 inhibitors, how many of them are actually at risk? RAS blockade is also vulnerable. You know that the CFR falls down a little bit and the creatinine slightly goes up when you start a patient on ACE inhibitor ARB. And RAS blockade is known to increase the creatinine a bit subtly, but it has been said that those with a slight raise in the creatinine are the beneficiaries ultimately of the ACE inhibitor therapy. When you see them after 3 years or 5 years or several years after changing, rather than stopping the drug by looking at the elevated creatinine in the initial phase itself. So better not to stop any ACE inhibitor ARB by looking at the slight raise in the creatinine, unless it is more than 30 to 50% and above initially, and then you can stop for a temporary period and restart with a low dose. But if you stop it, probably these people are not going to get benefited out of that. Similarly, associated other drugs like diuretics, SGLT inhibitors probably will make them more vulnerable. And you know that the cardiovascular outcome and the adverse renal outcomes with SGLT2 inhibitors over a period of time are known to get improved by the SGLT2 inhibitors. And these drugs are known to improve that. But the several meta-analyses showed that and reduce the risk of kidney disease by 37%, AKA also by 23% overall when compared to the placebo by these drugs called SGLT2 inhibitors. The overall, the relative risk for the kidney failure in some component of this particular outcome in the CKD trials was 0.67. There is no evidence that the relative risk reduction differed depending on the baseline GFR. The patients with the CKD are more vulnerable to get injured easily when compared to those patients with the non-CKD. That's why, of course, we see even without any kidney injury initially to start with, also are vulnerable for AKI that we see with the contrast-induced nephropathy in ICCUs. But still, CKD underlying subtle fall in the GFR initially makes them more vulnerable for development AKI. That's why a patient already is established CKD, be careful in using them. And if at all you have to use SGLT2 inhibitor, we need to monitor them frequently so that it will not adversely affect the kidney outcome initially, at least in the initial period. And several drugs have been used in concurrently. And my thing is actually not about preventing the people from writing SGLT2 inhibitors or any other drug, but concurrent medications have to be taken care properly, especially when they are given proton pump inhibitors, which are the major drugs in intensive care setup and even outpatient blockade with a change in the lifestyle of the patient with acid reflux and other. And proton pump inhibitors makes them more vulnerable to develop other important drug therapies which are protective to the kidney in the form of ACE inhibitor, ARB, and SGLT2 inhibitors and other drugs. So concurrent medication also should be taken into consideration, and trying to avoid the dehydration and the major part of the sepsis in intensive care is very, very important, for which the diabetic patients are very, very vulnerable, and so that they will not get into chronic kidney disease and end-stage disease later. So AKI risk should be established or explained to the patients in every time and they will get into admission into the hospital ICU, and they should be monitored frequently. And beyond the discharge also, they should be followed up for a long time. It has been said that those patients who are discharged with AKI with type 2 diabetes should be given an ACE inhibitor ARB. And these people, after a few days of initiation of the therapy, have done much better when compared to those patients who were not given ACE inhibitor ARB with the feeling that probably they might injure more. So we request that the patient with AKI, after established with a decent creatinine, then we can start them on ARB therapy so that their kidney can be protected for a very, very long time. So the AKI looks very subtle, but the definition also says that it is supposed to improve totally. But the type 2 diabetes patients with AKI are more vulnerable to develop CKD and end-stage renal disease compared to the non-diabetic patient. That should be known to all of us. So thank you very much for the kind attention and the patient here. Thank you all.